Thank you all so much for your incredible questions. We are going to take an assortment from across the range of what we were given. If, like I said before, if your question is not answered for any reason, as long as you provided a phone number or an email address, we will follow up with you and get you information that you need. I've already spoken to a few of the speakers and we've parceled out a few of the questions, and they'll be following up with you directly with some folks. But so this one kind of caught my attention, and it does say, "Excuse my ignorance, but there are writings that suggest Muhammad Ali has Parkinson's disease due to repeated blows to his body, including head. Why is boxing now suggested as a benefit to PD patients?" I'm going to toss that right over to Alex.
All right. That's a very legit question. Well, yeah, Ali has Parkinson's, and yeah, he was a boxer, and yeah, he got hit a lot, but a lot less than any other boxer that I know of. Because he was faster. Dude, well, look at him. That's true. On the other hand, yeah, getting hit in the head doesn't help anything, including Parkinson's, but it does not give you Parkinson's. And you don't get hit in the head, you don't get hit at all when you do this with us, because it's non-contact. Right. So part of what we do is parring with me, and you can hit me, but I don't hit you back, so that's a pretty good deal. Not in the face, but everything else is game, you know? So that's the answer to your question, yeah.
Excellent. So I think this is a question that does affect people at various stages of their life, and it's a great question. So the situation is they've had PD for 14 years. It was well controlled for the first 12 with various medications, including carbidopa. The hallucinations developed at year 12, and then reducing, pardon me, I don't know how to say all the medications very well. The ropinirole? Okay. Didn't work. So, and essentially other medications are making the hallucinations worse. And, you know, the caveat is please help. So I'm going to toss this to Dr. Katz.
Thank you so much. That's a really great question. I think that maybe other people in the room can relate to at least some aspects of that question. In general, as Parkinson's progresses, there are hallucinations that can happen from Parkinson's themselves, from Parkinson's itself, and also the side effects of the medications include hallucinations. So if you give anyone enough Sinemet, they will hallucinate, and so the mixture of that becomes kind of a setup, possibly for many hallucinations. We do try to reduce the carbidopa-levodopa dose as much as we can. Of course, many people notice that if we reduce it, they have trouble moving, so that becomes limiting. There is a medication that we typically try. There's actually 3 of them in the same class, and so the one that has the most evidence is starts with the letter R. It's hard because I wish I had a board I could write down, but it's called, the brand name is Exelon. That's easier to spell. E-X-E-L-O-N. And you know, people can be on it for different conditions, but it is actually the most effective for Parkinson's. It's much more effective in Parkinson's than other conditions that it's prescribed for. So the most evidence is for Exelon, and there's other medications in that class, and that medicine can be really significantly beneficial in Parkinson's. It can take away the hallucinations completely. It can allow people to tolerate more medicine. It actually is proven to reduce falls and improve balance in Parkinson's by 50%. There was a trial that just came out last month. So the other medicine I think that was on that card was Seroquel, that was tried and was not beneficial. And Seroquel can be helpful, but there is a black box warning with that medication from the FDA that can be a life-threatening arrhythmia. So I usually, Exelon or medications in that class are really the standard of care for to help, and can be really life-changing. So should be tried at up to the maximum dose.
Great, and while I have you on the mic, I did have someone ask if you could say and spell the 2 drugs that are neuroprotective.
Oh, sure, and I will also, I guess I'm not sure how to distribute the slides, but so the 2 medicines that right now, it's actually, there's only 2 medications there. They work the same way. One's cheaper and older, one's newer and more expensive. The cheaper, older one is S like Sam, E like Edward, L like Linda, E like Edward, G like Greg, I like Island, N like Nancy, and E like Edward, so Legiline. That's the medicine that gives you a little bit of an amphetamine kick. So I actually don't prescribe it for people over the age of 70 because it's just, as people get older, they tolerate things a little less. So the newer drug is better tolerated, and that is R like Robert, A like Apple, S like Sam, A like Apple, G like Greg, A like Apple, L like Linda, I like Island, N like Nancy, and then E like Edward. I wish they just had shorter names. But again, this is a really hotly debated topic. I think there's enough evidence to say that it could be neuroprotective. The FDA has requested further trials, and if you come to any movement disorder society meeting, you will see kind of thousands of people yelling at each other about this. So it's a passionate topic of conversation among Parkinson's specialists, but rasagiline is very well tolerated, and there is a potential for neuroprotection with that. I also mentioned caffeine, 2 to 3 cups per day. It has been shown to reduce dyskinesias, and there's a potential neuroprotective benefit for that as well. Maybe chocolate, maybe.
Chocolate just makes you happy and fights the depression, right? So, a little piece now and that couldn't hurt anybody, right? Okay. So we're going to toss the next one over to Roberta. And it says, does gene therapy need to be repeated, or is it a one-time surgery?
So what we are aiming for is the one-time surgery. In the past, there have been some trials where they have to repeat it, but that's really not effective. That's not what you want to have for a future cure with gene therapy. You just want to have the one-time surgery, and that's it. Like when you do DBS, you'll hope to have it just once.
Okay. So we're going to toss it over to the exercise folks. And who loved those exercise demos today, right? Those are amazing. Y'all are incredible people. So when you tell me that you can't do it, I'm not going to believe you anymore. So for the exercise team, what exercise resources are available for exercise professionals to be the most effective to get positive outcome? And this was originally directed at Erin, but anyone from the panel, feel free to jump in.
Okay, so this is a good question because we talked a lot about how having specific feedback and exercises and people who kind of know what you need is going to be the best for you. So some of the programs that can offer training for people, either therapists or fitness instructors, there's a program called PWR, P-W-R, Parkinson Wellness Recovery. They offer training for both physical therapists and fitness professionals. So I'm power trained, Robert said he's power trained, and also Jazzy is an instructor trainer at our clinic, and she did the power training as well. So you can have a caregiver go to the fitness training for power. You can have a family friend who wants to help you exercise go and get trained. Another trainer, any fitness professional could go and get this training and then have a greater knowledge base for how to help you work out better. So that's a really good one just for anyone. For therapists, there's also training like LSVT big training that they can do. That one is a kind of a specific protocol. Not everyone is great for the exact protocol, but doing that training would give you good knowledge of things to do with patients with Parkinson's as well.
Yeah. Oh, just to.
There's other resources online that you can go to as far as like getting education and different examples of exercise. YouTube videos can also be always a good resource. Like sometimes if we're fishing for ideas, we'll search on YouTube for some different exercise videos.
You're on the reactive site, correct? You have some posted on the website.
I think we have some videos posted on our website, yes. And actually we're developing an online subscription service for video exercise programs for people. It's still, our contract is still kind of in the works creating these videos, but I think that's something that might be more readily available in time. But basically what you would do is become a member of an online service of this fitness site, and then you would subscribe and get videos of exercises. And we're doing the exercises for people with Parkinson's. And then there's also yoga, but I know even my yoga studio has videos online that you can do, or Tai Chi videos that you can do. Videos don't give you that feedback, of course, but it's still beneficial. It's obviously still a useful thing that you can do and you can learn from as well. Do you guys have any other ideas?
And they can feel free to correct me, because sometimes I'm wrong. But if you go to several classes with your physical therapist, you go to these highly specific Parkinson's classes, you have opportunities to work out at home in a safe environment where you've got someone, watching you, or if you're doing it with a friend, you can go back to get that personal instruction depending on what your financial means are to be able to go to these classes actively. It at least gives you an opportunity to get that specialized instruction at various points, but also that you're still working out in a safe environment, especially for something like yoga or something where it might be a little bit more, there could be some more challenges. So feel free to adjust my thinking on that, but at least you get some, personalized instruction that's specific to you and what you're most passionate about to continue your exercise. So the questions kind of start to vary a little bit. So I actually kind of like this because there's still quite a few couples in the room. So for those of you that want to rekindle the romance a little bit, how does PD affect sexual function? And is that an early side effect of PD? And they do add the caveat that people don't really talk about this. I'm sure it's a little hush-hush. It's very personal what happens in our bedroom, I'm going to open this up to the panel and figure with you, Dr. Katz. So let me just toss this out there and let's see what we find out.
Well, I think it's a really, really important question, and it's true that it becomes something that people don't really talk about, even with their physician. And sometimes my patients will ask me that after I've known them for a couple of years. They say, well, there's something else, and it's been affecting their life for years, and it really just should be talked about openly. It's just so important to someone's overall health, quality of life. Parkinson's can affect sexual health in terms of causing erectile dysfunction. And so I prescribe medications for that, most commonly Viagra. There are other types of medications, and so if that's the case, I would just encourage everyone to talk openly with their physician. We're doctors, it's all this, it's just, there's just no big deal. There's no topic of conversation that you shouldn't be comfortable discussing with your physician. And there's treatments. That's why those medications exist, and they've been made available to people. So it really should be, I hope it becomes more of an open discussion.
Yeah, jump in. The best part about Q&A.
I just want to add something. I know that today we talked a lot about the basal ganglia and all these brain areas, their controlled movement. But Parkinson's much more, and it could involve, we're still researching this, so I don't want to say it's exactly like this, but the hypothesis, the theory is that different brain areas are affected, and as much as dopamine lack affects the motor areas, they can affect other brain areas. So it's a matter of lack of dopamine, serotonin, and other of these molecules in other brain areas, and that's where all these non-motor symptoms come from. Because sometimes it could be confusing if you wonder why do I have all these non-motor symptoms if the brain area that is missing dopamine is the one that controls motor function. But there are other areas involved, and when dopamine is missing, this can happen.
And one thing I'll add, I have I work with support groups all the time, and I've got this really phenomenal wife that supports her husband as his primary caregiver, and he had young onset, and they're still very early in the disease. She's like, I love my man. I want him to be my man for as long as he can. And husbands, I'm sure you feel the same way about your wives. You want them to be that person that you fell in love with however long ago. And so for them, one thing that they've pursued is counseling. They actually go to a marriage counselor just to keep that. They want to keep the love there as long as they can, because they know that ultimately there's going to be a point where she just is the primary caregiver, and that's a much more difficult thing, as things go along. But while they can, and while they can still be good to each other and passionate with each other in whatever way that presents to them, that counseling has really provided them both an opportunity. Even if they don't feel they need it, they still go, so it gives them a chance to air whatever it is, because sometimes there's things happening between us that are hard to talk about. So you're like, I love you. I said, in life and death and sickness and in health, and this is what I took on. So I do feel like there's other opportunities in other ways, short of just going out and trying to Google anybody to help you with that stuff, because Google's great, right? Google's got everything. I would say there is a new book that's come out. It's CareMap, CAREMAP. And it's caremap.parkinson.org. I have copies of the book. This replaces caring and coping, and there's certain aspects that it's a follow-along workbook that goes across multiple areas of your life with Parkinson's. But it does talk a lot about your relationship and your interrelationships with your family. And there's videos that you can follow along with online. So I'll just throw that out there, so if anybody else is looking for other resources, they want to try to cross a barrier and they're not quite sure how to, or call the helpline. Trust me, you will not be the first people that have called going, I don't know what to do. So it's great. Had a great question come in. I am on Azilect, very expensive, but works great with no side effects. Bonus. For 10 years. How would I go on selegiline, and what differences would I see? So it's probably another, toss it out to probably Dr. Cass.
Well, the first thing I would want to know is how old that person is who wrote the note.
83.
Oh, okay. Well, I think in general, I would be very hesitant to start selegiline, just because I'd be nervous about agitation, even hallucinations. We had, there's a new form of levodopa called Rytari that came out, which is long-lasting. And I work at the VA, and they were basically requiring us to start people on selegiline first before they would approve Rytari, because it's so expensive. And so we had a few people go to the hospital who were older on that drug. So we basically, of course, we basically refused to prescribe it. And because of that, so I would say if you're in your 80s and you've been stable on this medication, I would be extremely hesitant to switch.
Okay, another exercise one to toss out. But following up with Roberta, you're going to be in the hot spot in a second. So we have a good PT, but Medicare only allows so many visits per year. How do you continue with the PT if you can't pay out of pocket? And I think that's a great question.
So yeah, that's a great question. It's a question that affects everyone, every PT provider. It affects all the Medicare beneficiaries, and probably all of you. So there are a lot of creative solutions to this, though. So what we do, Medicare does allow for quite a few visits, actually. They start out with it's a dollar amount, not visit amount. So they start out with a certain dollar amount, and then you can also get an extension of that. But before we go there, what you can do is try to work with your professional in the clinic and have them try to spread out your visits a little bit. So building up all your visits in only one small time period is going to wear you out before the end of the year. So one strategy that we use is we don't see people 3 times a week, 2 times a week very often, usually once a week. And then as time progresses, maybe even every other week or every month or so. So that requires quite a bit of a team effort as well. So you're starting with your PT, you're getting a really comprehensive program of your exercise, and then you're doing a lot of this stuff on your own. You can't come to PT so many times a week, so you need to do a lot on your own or find other people to work out with you so that you can spread your benefit out across the year. The other strategies that you can do that are helpful and creative are you can work with somebody who's not a physical therapist but still in the clinic for a certain amount of time. So for example, we have like Jazzy, who is experienced working with people with Parkinson's, and if she works with you and I work with you for 30 minutes, we can only bill Medicare for that time, and then she maybe works with you for the other 30 minutes, and you don't bill Medicare, but you still get a lot of exercise time. So you can use support staff in clinics to help with that. We also get physical therapy students. Now, physical therapy students don't have a PT license, so they can't bill Medicare. So PT students are very capable and smart. They could work with you and get you a great workout without charging Medicare, so you essentially get some free treatment that way. Other things that you want to do are work with other professionals like trainers and other fitness people that can help you do your exercise program a little bit better without using your Medicare benefits. We find that our Medicare benefits do last people throughout almost the entire year, especially if you go once a week or once every other week for a little period of time, as far as like sometimes you're out of town or you're sick or whatever, it can actually extend your benefit. As well as group classes. That was the other thing that we developed because of this limitation on how many times someone can come for individual therapy. Group exercise classes are a great way to keep you fit and motivated and participating in things, and you don't use your Medicare benefits for that. So they're usually a little cheaper than one-on-one because you're splitting the cost between a big group of people. You could even, if there's multiple of you, maybe you can even approach someone and say, can we do like a little group discount rate on a training session together with someone who has some experience, and that you can split the cost that way. There's a lot of really creative and great ways that practitioners can help you still get the services you need over the course of the year. Medicare provides great benefits to people, but yeah, they don't pay for you to go every day forever, so you just have to be smart about how you use it. Do you guys have any added thoughts?
I was just going to add to the group, there's a lot of evidence that actually the group therapy has an additional benefit, which is the interaction among the people in the group. And there's really mounting evidence that that is as beneficial as the physical aspect of the exercise.
Just one thing. When you do work out with a trainer who's not a physical therapist, though, talk to them first. Make sure that they know what they're doing. They know what they're dealing with. It's true, because, you know, it's sad, but most of them will say, if you say something like, hey, you know what, I have Parkinson's, I have very specific needs. Can you address those needs? Well, they'll say yes. Truth be told, 80% of the time, no, they don't. You have to make sure that you're dealing with people who know what they're doing. They know what they're doing physically, and they know what they're doing psychologically. Because even the line between pushing someone and being annoying is really fine. And they, well, just talk to them.
Yeah, I'm interested. So the $1,500 cap, I think, is only with physical therapists in a medical center, right? And not the independent physical therapists in the
Everyone.
It's everyone now? Okay.
I can talk about the cap in a second too.
Bring it out.
The Medicare cap is The initial cap is, what was 1,200, 1,500, 1,400, something like that. So there's an initial cap of $1,300, $1,400, $1,500 or whatever, and it's billed by the minute. So that also depends on how long your visits are with your therapist. So if you schedule visits that are 45 minutes, they bill 45 minutes of therapy, and that's all that Medicare pays for. So if you schedule hour-long visits, then they pay more per visit. So you have less visits over the course of the year. So kind of keep that in mind as well. And then the other thing is there was a class action lawsuit several years ago for people with chronic degenerative diseases that Medicare had to overturn their rule saying that you can't continue to get therapy if you're not making progress, if you're not making gains. So now you can still get therapy if you have Parkinson's disease because it's a chronic disease, and there's evidence to show that without that therapy you could decline in your function. So your therapist can submit billing that shows that you still need this therapy to get an extension of your therapy services to $3,800, and that can give you about 30, 35 visits for the year. So it's actually quite a bit of visits over time. You can find these resources and information online if your therapist is like, no, we can't do that, or we won't do that. You might encounter some problems with people doing that, but the truth is you can get an extension of your Medicare cap so that you can get therapy for longer because of your disease, even if you're not making progress. Even if you're staying stable, even if you're declining a little bit, you can still get that because you need it to prevent even more decline because of the Parkinson's.
One thing that I'll throw out there as well, I had to have my own physical therapy for a surgery I had a few months ago. And I went in and just ask, because I'm sure every physical therapy office is different. But they told me that their gym would be available to me whenever I wanted to go in and work out. I could get on the cycle, I could get on the treadmill. As long as I was being actively seen by a physical therapist in the office, I could go in and use their equipment. So we took one of the sessions and they showed me how to use everything. So then I would go in for the first 30 minutes before my appointment and warm up on the machinery the way they told me to, and then I would do a 30-minute appointment. So I was able to take that time and extend it out to almost an hour with people around me. So, God forbid I fall over or something, somebody can, they're there to help me, right? It's great. And you're in a safe setting. And so you have this benefit, but you don't know if you don't ask. And the worst they're going to tell you is no, right? So go ahead and ask and see if that's something that they can do for you. So a gene therapy question for Roberta. Why do you favor a 3-gene injection of genes for surgical treatment of Parkinson's?
Well, the thing that I didn't get into details, that there was a trial before the 3-gene trial. They used only one of them, and it was promising, but didn't go through the whole 3 phases of clinical trial because of effectiveness. Excuse my accent. So it seems like having the 3 of them, which are all involved in the pathways that create dopamine, is way more efficient and effective than just having one of them. They just potentiate each other, so you really produce dopamine more.
Excellent. So tossing this one back to the exercise team, I think, Beth, I feel like one of these is probably going to be a little bit better for you. So there were various, you were talking about the level of exertion of force in effectively treating Parkinson's symptoms. Is there any other aspect of exercise that's going to go ahead and add to that effect?
Right now, that's really, it's all that we really understand at this point. There seems to be both an aerobic component and this skill-based, goal-oriented component. And the aerobic component obviously is getting your heart rate to a certain level of activity or having that kind of intensity. But there has not been any study that's looked at specific dose response in Parkinson's at this point.
Okay, and I actually wanted to throw a question out there at you as well. You talked, and we were talking last night, we did have dinner with some of the speakers last night, which was great. And you were talking a lot, and you've mentioned it several times today, of the idea of the self-efficacy, the fact that you can do it. You know, you might look like a kitten on the outside, but gosh darn it, you're a lion on the inside. Isn't that amazing? So I would definitely throw that out and say, you know, for those folks that maybe need some tips as far as, you know, self-efficacy, and, you know, what kind of things can people be doing to kind of start that process of self-efficacy for themselves, or what can their caregivers do as well? Because sometimes the tensions mount and things like that, and it can be difficult to break through. But, you know, you're talking about your study and the idea that, you know, those who are being spoken to and coached are seeing a much better result. And I would really love for you to speak to that a little bit more, maybe, and kind of give the caregivers some tips and you know, a little back and forth, but that would be great.
Well, it's just an interesting, I think it's an important phenomenon that's being studied a lot, and that is that motivational enhancements seem to be really important factors for improving function. So it's, how do I put this? We think about what layers do we want to be able to peel off and then help people improve their functional capability, and it would seem that motivational enhancements is an easy thing to do. And I think that a lot of that people have already spoken to, just the idea of that not trying something because you believe you can't do it, and then trying it and realizing that you can. I think that that's, you know, the critical aspect of what everybody's been talking about, and maybe being in an environment where you feel like safe to try that. And but what the research is indicating is that belief, that knowledge that you can actually do something has a huge impact on the capability the person has. It's really, it's not just, you know, gee, making somebody feel better. It truly impacts their motor performance. Did you want to add something?
That's very true. And the other thing you need two things in my experience. One is a stranger that you can trust. Because when it's different when your caregiver tries to push you. There are dynamics, psychological, emotional, that you cannot just strip down and just forget when you do that. When you find a stranger you can trust, that doesn't exist. It's just that relationship. And it's just, it's limited to that particular context, and it works. It's like a therapist. Why doesn't a friend that works just as well as a therapist? Because they don't charge you. Well, no, it's true. And it's not a controlled environment, and it's not a setting. So a stranger you can trust, and the other thing you need is a final goal that doesn't have anything to do with exercise. If I have someone who used to play guitar, right, and misses it a lot, which they do, you can talk to them and say, look, if you do this, this, and that, you stay on top of your medication regimen, you exercise, you are proactive, then you'll be able to play again. That makes a difference. You know, so they do everything else to get to that point.
I wanted to call everybody's attention to a paper that really, I think, relates to this whole topic. It's actually a paper that was published in 2012, and the lead author is Chiviakowski, but Rebecca Luthwaite has done a lot of this research, Gabby Wolf, spelled W-U-L-F, and it's basically looking at people with Parkinson's disease, two groups of people that were on what's called a stabilometer. And that's a balance task, like a teeter-totter. And it's very challenging. So it's really, you're looking at people who have balance problems, performing this balance task, okay? One group was given the choice to use a pole whenever they wanted to, on whatever trials they wanted to use a pole like a tightrope walker would. The other group, there was a person in the other group that was yoked to an experimental subject such that they had to use the pole on those same trials. Okay, you following that? So one group was basically the choice group and the other was not given the choice. They just used the pole for balance at the same time point. So as much as the other group did. And there was a significant improvement in balance during practice and long-term retention. Now, that's just giving someone a choice. So that's a simple thing for a caregiver to do in terms of exercise. And people have talked about changing it up and not doing the same order every day. But maybe it's not even the therapist or the trainer telling you what you're going to do, but, you know, I'd like to do this first, and then I want to do that, and just this idea of choice has been studied in people with Parkinson's disease and other individuals, and it's huge. It's a huge factor in improving motor function. So I don't underestimate how powerful those things are.
Belief in yourself and power you choose.
Yeah.
Absolutely. So one particular, she had multiple questions. So I'm probably going to pass off a couple of them because they're a little more specific to them working individually with a movement disorder specialist or with a neurologist, preferably movement disorder specialist, because some of this seems kind of particular. So I'll either have Dr. Katz follow up with you or with the helpline. But there was a couple of other great questions on here. One was, what are some of the specific pesticides that cause Parkinson's? Do you happen to know them by any chance, Dr. Katz, or anyone?
Yeah, please chime in if I miss any. The two that have been the most studied are paraquat and rotenone. Those are the two. Paraquat is an organic pesticide, which means that it was used in organic farming. So when someone says I'm an organic farmer, they are still using organic pesticides, and nature makes the best poisons. It's much better than humans. Paraquat is now illegal. It's not used, if you get fruit that's organic from China, I think, it can have paraquat on it. And also some marijuana plants that come from Mexico have paraquat because the US government in the 70s tried to kill off all the marijuana plants in Mexico by pouring paraquat on them. So just, but right now paraquat is not used in organic farming anymore. Rotenone is still used. It's a very powerful company of man-made pesticide, and if you go on their website, they talk about just how much benefit they've made to humanity. There is a ton of evidence now showing that people, their risk of Parkinson's is correlated to their exposures. All of that research actually came from Dr. Caroline Tanner, who's at UCSF. She's spent a lifetime working on this, and in fact, if you give rotenone or paraquat to animals, they develop Parkinson's that is pathologically identical to human Parkinson's disease. There's some organochlorines that are used in dry cleaners as well that increase the risk of Parkinson's. And Dr. Tanner just published an article where some of the organochlorines that were used for pesticides in Hawaii a couple of decades ago, actually, she then looked at the milk consumption of those people and found that a correlation with their non-organic milk consumption and their risk of Parkinson's. And then she found remnants of those pesticides in their substantia nigra.
go ahead. I mean, just.
I was in a study at UCLA that studied with the chemicals, and manip was one of the other. It was a fungicide that came up with the study also.
So that was a great question. Thank you for throwing that one out there. And I think this is actually a really great question for across the panel. And that is that they don't show symptoms most of the time, yet they still have balance issues and either almost fall or fall. And the question is why? They say they're very active, they play golf, yet they shake more when they're hitting the ball, obviously mostly putting. But I think it's a great question either from the PT side, the neuro side, across the board. You know, what are some of the reasons why maybe the symptoms aren't quite so severe that they're still having significant balance issues?
Can you repeat that?
Yeah. So if you don't have a lot of symptoms that are present at the moment, but you have PD, and you have an issue where you're falling or almost falling a lot of the time, even though, you know, is there a cause? Is it like a physical cause? Is it having something to do with the substantia nigra and with the brain is working? Like, what is maybe perhaps causing the falls, even though they still tend to be a fairly active person?
Well, one thing we know, and Dr. Katz, correct me if I'm wrong on this, is that dopamine replacement therapy has less impact on postural control, and that is, that's one factor, I think. The other thing is if that is an early sign, like the first thing that's happening is falling, as opposed to other type of symptoms, it may be, as Dr. Cass was talking about, it may be not idiopathic Parkinson's disease, but one of the Parkinsonism disorders. Just something that I think, coming from a motor learning perspective, sometimes it's the case that we have to think about what we're doing until it can become more automatic, perhaps. And there is evidence that there is some spared automatic capability, and that, in fact, by doing a lot of the training where we're using auditory and visual cues, we may actually mask some of that. But again, from a motor learning perspective, you may start out having to think about it, having to really process information about staying upright, not falling, and then it becomes more automatic. So I would suggest if somebody is experiencing that, they at least adopt that kind of cognitive process first. Does anybody else have?
Yeah, also anxiety can play a big role in that. Because the way your brain works against you is that it goes straight, whatever you do, which is now a task, not just an activity that you just naturally do, becomes a reason for anxiety. So what your brain does is projects you in the worst possible scenario, right? So you don't even realize that, but as soon as you try to take a step, your brain goes right there where you're falling and tripping and freezing. And guess what? You do freeze and you do trip. And unfortunately, sometimes you do fall. Now, the answer to that, it would be easy to say, well, just don't get anxious about it. It's not that easy. A good way to go that we tried is just break it down. Every task is a complex task, even walking. And it entails so many different movements and so many different actions that you have to do at once that you may have to start with one. And don't if your legs freeze, well, focus on your arms. If you bigger ball. Right, exactly. It's true. anything that takes your mind off of that kind of situation where there is a performance anxiety involved. Because guess what? Right now, everything is like a performance, and the bar is always set somewhere, and you want to be just as good as you were before, and it's really not about that anymore. And it's a good thing, actually. You can use it to your advantage. You know, there is no bar. Just here's the task. Let's get it done.
I'm gonna hire you as my motivational. No, I mean it's like so I'm gonna just piggyback. So we don't understand what causes postural instability too well. We know that it is typically not responsive, as mentioned, to dopamine. Or DBS, yeah. DBS won't help falls. So this medicine that I mentioned, the Exelon and its cousins, can reduce falls and imbalance. And in Parkinson's, the falls and imbalance are due to postural instability, which is this lack of, every time you kind of shift and move, your body has to know how to keep you upright. And in Parkinson's, that ability, that postural reflex with any kind of change or shift is diminished. But there's also a cognitive component to falls and imbalance in Parkinson's, so it's about inattention and impulsivity. So a lot of the times people will say, well, I just saw a book on the ground, and even though I know I'm probably gonna fall, when I reach down for it, I didn't think about it in the moment, I just reached down for it. Or when people turn, they just kind of swing around and do like a very fast turn rather than taking their time. So it's a cognitive process in Parkinson's. Attention and executive judgment can be reduced. So I think that the Exelon's effect on reducing falls, which the recent study showed by 50%, I think is more about the cognitive portion and about improving that attention. If you're going to need to take your time to take a turn, you take more of that time. Maybe you don't reach down for that book. Maybe you ask someone else to help you. Maybe you get into a safer position before you reach down for it. So that's one aspect. The other aspect is vitamin B12 deficiency is higher in people with Parkinson's disease, probably because of the way levodopa is processed. Vitamin B12 causes imbalance. It actually it specifically affects balance. So you want to make sure to get your vitamin B12 level checked. And also low vitamin D has been related to falls in Parkinson's, a mechanism we don't understand. But again, we're in the medieval ages of neurology. And so, but we know that if we replete vitamin D, people fall less. So B12, vitamin D, and Exelon.
So is it a follow-up on the B12 or?
And the vitamin D.
The D, yeah.
What are the
B12 and 6?
what are the dosages recommended for optimal, not necessarily the normal range, but what's the optimal recommended on both of those?
Well, I would always recommend just getting your level. Oh, what's the normal level?
Yes.
Okay, not the. Are you asking the normal level or the normal like supplementation? How much should you take?
No, the
level. Yeah.
Level.
Yeah. Okay, so people who are above 300 in their B12s are normal, almost always. If you're below 300, then you could be low for you. So there's some supplementary labs that are then drawn in order to make sure that people have enough for that specific individual. So it's typically if it's below 300, then we check other additional labs. So B12 is a little more complicated than just the level. And then for vitamin D, I like to have everyone above 30.
So it is approaching 2:30. We promised we would shut this bad boy down right about then. So I did just want to there was one question that was actually kind of put out there for NPF, and I just wanted to address it quickly. And it was, you have a person in Southern California and a person in Northern California. Why not Central California, where you have a great number of people, right? It's a great question. And I was talking with the Fresno group a little bit while they were enjoying lunch earlier. Sarah and I, being here, we're emerging markets. We're trying to establish these chapters. We're trying to build staff in this area, but unfortunately Rome was not built overnight. And we're going from being a national organization in Miami to now trying to become across the state and have various employees all over. So I would say dream big, live big, right? Okay. While we would love to see more staff across the state, we simply don't have the financial resources in order to keep as much money into research, into free programs and services. We know that that's where the critical piece of our system lies. So what I would ask is for your patience. Please, please, please reach out to Sarah and I whenever you need anything. Call the helpline. Let them help you where they can help you.
Contact information on the back of your program.
Yes, or on the back of the NPF flyer is my contact information. If you have Southern California questions and you can't find Sarah, I will forward your questions to her. We're on the NPF website, whatever you need. And I will say, there's 2 employees in the state of California. We have probably about 35 states where there's no one. So it's going to take us some time. But I will say we have decided that we don't want to go alone anymore here with NPF. And we are currently in the process of a merger with the Parkinson Disease Foundation. So we've decided that these 2 incredible, strong organizations that have been in huge service to the patient community are going to join together, because we figure we can do more together than we can apart. And we need a little less competition, a little more unity. So we're currently in the legal and financial process of the vetting to make sure that we can do this. And hopefully, as long as there's no glitches in the system, we're anticipating to be fully merged with both organizations by this summer, and anticipate a new name and some new branding as we go throughout the end of 2016 and into 2017. So we've heard that we need to have a little bit more inclusion. We need to be figuring some more things out. And as organizations, I can tell you that it is happening. We are listening. We are hearing you. So again, please reach out to Sarah and I when you need things, and we will do our level best to give you every piece of information that we have at our disposal. I do just want to say one thing quickly. Leslie, if you want to stand for me, if anyone is with Kaiser and would like to see more action and advocacy with Kaiser being here in the Central Valley, please go see Leslie. And she's
phone number, please.
Yeah, so she's going to be working on that. I'll have you guys talk with her. But right now, I really want to thank this absolutely incredible panel of people and for all of you being here today. This is for you and about you, and I guarantee you will be seeing more of our smiling faces. So thank you all so much. And for those of you that either want a support group or would like to talk about some support group ideas, PPSG is going to have the room here for the next little bit. So take a few minutes. And Sarah and I will be out in the hallway to answer questions for those who are leaving. And we're going to let PPSG come up and have the room for just a little bit. Oh my gosh, guys, I am so sorry. I completely forgot. There's a palliative care clinic that Dr. Katz is working on that's been sponsored by Pecori. And it's really fantastic. I promised her I'd give her a minute. I think you should hear about it. It's a flyer in your bag, but I'd like her to tell you about it.
There's a flyer that's in each of your bags that I just wanted to point out. I had a little presentation on it, but I talked way too long about disease modifying therapy, so I didn't get a chance to talk about it. But this is the first clinical study of incorporating palliative care, which is really just a focus on reducing symptoms, reducing suffering, improving quality of life into the care of people with Parkinson's disease. And so we have a multidisciplinary clinic where it's a neurologist, me, and then we have a pain specialist, palliative care specialist. We have a Buddhist chaplain. She's a meditation specialist, and she teaches a lot of mindfulness and meditation techniques. A social worker, and then a clinical nurse with decades of experience with Parkinson's. It's a randomized clinical trial, and so basically in order to get Medicare to pay for this kind of multidisciplinary care, we have to prove that it works. That it helps people. We're looking at improving quality of life and reducing caregiver stress. Those are our goals. And basically we can do the first visit in person in San Francisco, and after that we can do all visits via telemedicine. So if you have Skype, then we can see you. And it is a randomized trial, which means that basically it's like a flip of a coin to go into the treatment group or the usual care group. Everyone continues to receive care with their primary care doctor, their current neurologist, then also gets the specialty care and the multidisciplinary care with us. If people randomize to the usual care group, then they'll go into the supportive care clinic in a year. So everyone ultimately gets the care. But it's an innovative way to basically look at how we can improve care for people with Parkinson's, and it's the first of its kind, and I hope that you consider joining, and the number to call is right there. Okay, thank you.